Non-surgical periodontal treatment. So let's go into step by step. How can we start with a diagnosis until we finish treating the patient? First of all, comprehensive periodontal assessment, and that is based on our 2017 AAP EFP classification for staging and grading of periodontitis. So the first thing, you need to have the right records. So what are the right records that we do or we take from our periodontal disease patients? So first of all, your full mouth probing depth, your bleeding on probing, your clinical attachment loss, your recessions, your mobility, teeth mobility, furcation involvement, and also plaque score that will reflect your patient oral hygiene. Now, why are these records so important to highlight? It's because it enables us to reach to the accurate diagnosis and also to have the right baseline documentation of our patients. Step number 2. So risk factor identification. So it's so important that we identify what are the risk factors so we're able to control them. Or what are the risk factors that we can control and what are the risk factors that we can't control. So what are the key risk factors? Number 1 is smoking. 2 would be diabetes. So we always have to check for the HbA1c levels because that reflects if the patient is controlled or not over a long period of time in the previous 6 months, and also other factors as stress, genetics, and also medication. Step number 3, patient education and motivation. This is such an important part, and myself and my staff, we always make sure that patients understand why they are here and why the plaque and improving their oral hygiene is such an important part of the treatment. Because the nature of periodontal disease has to do with the role of biofilm and the host response and the importance of self-care and oral hygiene instructions. So we usually start by giving the modified BAS technique, how to use the interdental brushes as they are more effective in patients with periodontitis. And also sometimes we consider using chlorhexidine short term during the treatment period. Step number 4, which is supragingival biofilm and calculus removal. So in some patients, they will have huge amount of local factor above the gingival tissue and below it. So I think supragingival scaling will help to remove the calculus and also to improve the patient overall health. And that's by improving or giving the patient more spaces so they can clean interdentally between the teeth. So always provide a session with your hygienist, if you have a hygienist in your practice, that they're able to remove the supragingival calculus. It also helps to reduce your supragingival inflammation. However, don't do over-instrumentation because that can lead into difficulties to access to the deep pockets. Scaling and polishing is done to more remove the biofilm and the calculus, which is above the gingival tissue, and this is what you're supposed to aim to. Now, subgingival instrumentation, which is the root surface debridement. So in this case, we can use, as I have spoken previously about, which is your ultrasonic scalers and your hand instruments. So what is the goal of the subgingival debridement? Is to disturb and also remove your subgingival biofilm, the calculus, the endotoxins that this bacteria produce. So we usually perform that as quadrant or half mouth, or you can use the method of full mouth disinfection protocol. It's also indicated, and that is selective and different from one patient to another. So the most important thing is that you avoid aggressive root planing or over instrumentation. So we always focus on having a clean root rather than having this glassy smooth roots that may lead the patient to sensitivity that is hard to control. So scaling and root planing is effective in reducing pocket depth. It also improves the clinical attachment level. It's reducing your bleeding and probing. Sometimes we can use adjunctive antibiotics. However, if there's no added benefits, then there's no need to use them. We try to reduce using antibiotics as much as possible. Step number 6, so it's reevaluation. So reevaluation usually take around, say, 6 to 12 weeks, and that means that we reassess our patients. We take the same records that we take them initially and compare them with our current records and see if there is any improvement. So according to the reevaluation stage, we want to see stability. So if there's stability, we move to the maintenance. So what are the records that tell us that this patient have improved? That means there's no residual pockets, everything is less than 5 millimeter, and also there's no bleeding and probing, and the patient have improved their oral hygiene. So usually evidence, according to Cortellini and Tonetti 2015, they tell us that usually we get improvement from NSPT treatment from 1 month to 3 months post non-surgical treatment. Step number 7, which is so important. So with some referring dentists or some patients, they think that the patient will go back after active treatment phase and they finish with treatment. However, maintenance treatment is as important as the active treatment phase. We want to see if this patient is actually maintained over a longer period of time. So we kind of tell the patient to come back to us every 3 months, 2 months, 6 months, and that depending on the results we get from the reevaluation stage and also from the risk assessment. So we also assess the patient if they have improved their oral hygiene, plaque scores are lower, if the patient is still smoking or not. And according to all of these records, we tell our patients to come every 3, 4, 6 months over a 1-year period, and then we re-evaluate again. Oh, hello there. If you want to know more about evidence-based insights in periodontics, don't forget to subscribe to our channel, Healthy Gums Dentist or Keystone Periodontics, on Instagram, YouTube, or on Facebook page.